Imagine uh, feeling a profound physical change in your own body, specifically like a pervasive sense of looseness or maybe even the sensation of a physical object sitting inside you.
Yeah, which is incredibly distressing.
Right. And you go to a specialist, and physically, structurally, the scans show that everything looks completely normal.
Right.
But your brain insists the space is fundamentally changed. Today, we're looking at a diagnostic landscape that tackles the subject so many of you listening have experienced, or will experience, but rarely talk about openly, the postpartum pelvic floor.
Yeah, the postpartum body is just a site of immense structural and neurological change. But historically, the medical approach has really oversimplified the recovery process.
Oh, absolutely.
And that often leaves patients feeling like their very real physical sensations are just, being dismissed.
So for today's deep dive, we have compiled a massive stack of sources. We're talking clinical trials, advanced physiotherapy protocols, and peer-reviewed journals.
Some really heavy hitters, too.
Yeah, from the Royal College of Obstetricians and Gynecologists, as well as the International Urogynecological Association. And our mission today is to investigate a very specific, almost mind-bending question hidden in all this research.
It really is fascinating.
It is. The question is, can nerve stretching during childbirth actually mimic the physical sensation of vaginal laxity? Okay, let's unpack this, because we are talking about a feeling of looseness that might not actually involve physical space at all.
Right, and to get to the bottom of how our brains interpret what's happening inside the pelvis, we have to meticulously separate the mechanical changes of the tissues from complex neurological illusions.
Which is wild.
Yeah, and the medical community is just now beginning to properly map out this distinction.
Well, before we can wrap our heads around how a nerve might be tricking the brain, I want to establish what actually happens to the physical structures of the pelvis during a vaginal childbirth.
Good place to start.
Because reading the International Urogynecological Association data, I had to stop and reread a specific statistic.
The prevalence one.
Yes. Vaginal laxity, which they define literally as a subjective feeling of looseness, is reported by 34 to 45% of women at 6 months postpartum.
I mean, it's staggering.
We're talking about nearly half of all women who give birth vaginally experiencing this at the half-year mark.
Yeah, and that statistic is a clear indicator that the standard, 6-week postpartum checkup is just missing a massive portion of the recovery timeline.
Right, clearly.
And a critical first step in understanding this high percentage is distinguishing laxity from prolapse.
Oh, right, they're not the same thing.
Exactly. The two conditions get conflated constantly, but they are entirely different mechanical issues.
Okay, break that down for us.
So prolapse is a displacement issue. It happens when pelvic organs, so the bladder, the rectum, or the uterus actually drop. They push against or displace the vaginal walls. The organs are just not where they belong.
So prolapse is really about the contents shifting out of place.
Yes. Laxity, on the other hand, is about the elasticity and structural integrity of the vaginal canal itself.
Got it.
In a case of pure laxity, the organs might be perfectly positioned, but the surrounding container, the structural walls of the vagina, has fundamentally changed.
And reading about what that container goes through during delivery, the mechanics are intense. The sources highlight the levator ani muscle.
Oh, yeah. That's a major...
Like the main muscle complex acting as the floor of the pelvis, right?
Mm-hmm.
During a vaginal birth, that muscle stretches up to 2.5 times its original length.
It's incredible.
I'm trying to picture any other muscle in the human body doing that.
Yeah.
Like you can't stretch your bicep 2.5 times its length without completely destroying it.
No, definitely not. It is an astonishing feat of biomechanics. The tissue is uniquely designed to accommodate a fetal head. But, a stretch of that magnitude leaves a mark.
It has to.
Right. The research shows that this extreme distension sometimes results in an avulsion.
And an avulsion is?
It's a traumatic injury where the puborectalis muscle, which is a key part of that levator ani complex, is literally torn away from its insertion point on the pubic bone.
Like torn completely off the bone.
Exactly. Completely off. And even in deliveries where the muscle doesn't physically detach, the extreme stretching can lead to a permanent ballooning or like an overdistension of the levator hiatus.
Which is the central opening in the pelvic floor, right?
Right. The muscle fibers are just stretched past their elastic limit and fail to recoil.
But the sources also emphasize that it's not just a muscle problem. And that was a huge takeaway for me when digging through the physiotherapy journals.
Yeah, the connective tissue.
Exactly. Laxity is heavily driven by the fascia. I always thought of the pelvic floor as just a bowl of muscle. But the fascia is this dense connective tissue that anchors the vaginal walls.
Right, it's the scaffolding.
And during delivery, that tissue loses its tensile strength.
Well, the hormonal environment of pregnancy sets the stage for that. The body releases relaxin, which is a hormone designed to deliberately soften ligaments and connective tissues.
So the pelvis can actually open for birth.
Exactly. So you take tissue that has been chemically softened for months, apply the extreme mechanical trauma of delivery, and the fascia can become permanently overstretched.
Let me try to visualize this with an analogy from the sources. Think of the pelvic floor like a hammock.
Okay, I like that.
The muscle is the fabric of the hammock, and the fascia and ligaments are the ropes tying that hammock to the trees.
Perfect.
If the ropes, the fascia, are permanently stretched out and sagging, it honestly doesn't matter how tightly you weave the fabric or how strong the fabric itself is.
Right.
The whole structure is still going to sit too close to the ground.
The hammock analogy captures the mechanics perfectly. You cannot exercise a ligament back into being short and tight once it has been mechanically stretched past its yield point.
Which makes me question the standard medical advice we hear all the time. Like, when a patient tells her doctor she feels loose and the doctor just hands her a pamphlet and says, go home and do your Kegels.
Yeah.
I mean, they're completely ignoring the ropes.
They are completely ignoring the connective tissue. Kegel exercises, or pelvic floor muscle training, focus entirely on increasing muscle tone and strength.
Bulking up the fabric of the hammock.
Exactly, which is beneficial for certain types of incontinence or mild prolapse. But Kegels do absolutely nothing to restore the structural integrity of the fascia.
Wow.
A woman can diligently perform pelvic floor physical therapy, develop incredibly strong pelvic floor muscles, and still experience severe vaginal laxity because the underlying connective scaffolding is compromised.
That has to be incredibly frustrating for anyone who has done like a million Kegels and felt absolutely no difference.
Oh, incredibly frustrating.
But this is where the research takes a turn that I genuinely struggle to wrap my head around. We've established the mechanical side, right? The torn muscles, the overstretched fascial ropes.
Right.
But the data suggests that for some women, the sensation of looseness doesn't mean the physical space is actually wider.
No, it
It
doesn't.
means the body's sensory reporting system is fundamentally broken.
What's fascinating here is the role of the pudendal nerve. When we move from evaluating mechanical stretching to neurological stretching, a completely different landscape of postpartum dysfunction opens up.
Okay, so the pudendal nerve.
Yeah. The pudendal nerve serves as the primary sensory highway for the entire pelvic region. It provides sensory input to the clitoris, the vulva, the vagina, and the perineum.
It does a lot.
It does. It also carries motor fibers that control the sphincters alongside autonomic fibers. It is a highly complex, multifunctional nerve trunk.
And just like the levator antemuscle stretches 2.5 times its length, the research shows the pudendal nerve can stretch up to 3 times its usual length as the baby descends. 3 times.
Right, and nerves do not have the same elastic properties as muscle tissue. They are highly sensitive to tension.
I can imagine.
Furthermore, the pudendal nerve doesn't just get stretched, it gets crushed. As the fetal head navigates the birth canal, it can compress the nerve directly against the rigid pelvic bones.
Ouch. Like stepping on a garden hose.
A very heavy step on a very delicate hose, yes. This compression cuts off the blood supply to the nerve, causing ischemic injury.
Ischemic meaning like lack of oxygen.
Exactly. The nerve fibers are starved of oxygen while simultaneously being pulled taut. And we can quantify this damage in clinical settings by measuring pudendal nerve terminal motor latency.
Terminal motor latency. Okay.
Yeah, it's a diagnostic test that clocks how fast an electrical signal travels down the nerve pathway. 2 to 3 days postpartum, this latency increases significantly in many women.
Meaning the signal is slower.
Right. The nerve is damaged, the myelin sheath may be compromised, and the electrical signals are just moving sluggishly.
Okay. The sources mention that for most women, this nerve function recovers within a few months.
Thankfully.
But for some, the damage persists. And this brings us to the core focus of this deep dive.
Yeah.
The primary symptom women report with vaginal laxity is decreased genitopelvic sensation. They feel less friction, less physical contact during intercourse, or even just in daily life.
Right.
But pudendal neuropathy, the actual nerve damage, also causes numbness, tingling, and a loss of sensation. Wait, slow down. How does a nerve stretching make my brain think there's more physical space? It doesn't make sense to me.
It requires looking at how the brain maps the body. The brain relies heavily on friction and pressure sensors embedded in the vaginal wall to constantly update its understanding of the physical dimensions of that space.
Okay.
If those sensors go offline because the pudendal nerve has been stretched or starved of oxygen, the brain suddenly stops receiving that incoming sensory data.
So because the brain isn't feeling any pressure against the walls, it just assumes the walls have moved further away.
Exactly. The brain is a pattern recognition machine. It interprets the lack of friction as an absence of physical contact. A woman experiencing numbness from pudendal nerve damage may interpret the sensory void entirely as physical looseness.
Wow.
The actual physical dimensions of her vagina might have completely returned to their pre-pregnancy baseline. The levator ani muscle might be perfectly intact, the fascial ropes might be healed and taut.
But she still feels loose.
Right, because the pudendal nerve is failing to transmit sensory data back to the central nervous system, so her brain synthesizes the illusion of a wide, lax space. The stretched nerve is actively masquerading as a stretched vagina.
That is wild. It's an illusion created by a damaged data cable.
Precisely.
And the sources point out that this nerve damage can create other, even more bizarre sensory illusions. There's a medical term mentioned in the urogynecology journals, allatresthesia.
Yes, allatresthesia. It translates from Greek as the sensation of a foreign body.
Right. The clinical notes describe women reporting the distinct feeling of a golf ball, or like a heavy tampon, sitting just inside their vagina or rectum.
Very common descriptor.
But when doctors examine them, there is absolutely no prolapse.
Yeah.
There's no physical object. The structural anatomy is completely clear. It's just the damaged nerve misfiring and screaming at the brain, there is a golf ball here.
This raises an important question about how dependent our perceived reality is on the integrity of our peripheral nervous system. If the pudendal nerve is irritated, trapped by scar tissue, or still recovering from a severe stretch injury, the signals it sends are chaotic. It doesn't just send a simple pain signal.
I get confused.
Right. It can manifest as that specific golf ball sensation, or a burning pain, or the pervasive feeling of looseness.
If a patient comes in saying she feels loose, how on earth does a doctor figure out if it's torn fascia, a stretched nerve, or both? I mean, the symptoms are virtually identical to the patient. They both make you feel loose or heavy.
It demands a highly specialized, multidisciplinary approach. A quick visual exam with a speculum is not going to capture a pudendal nerve injury.
No, I wouldn't think so.
The diagnostic process involves a pelvic floor physical therapist doing an internal assessment to check muscle tone and feel for those avulsions. Specialists use translabial ultrasound to visualize the integrity of the muscle and the fascia in real time.
And for the nerve.
For the neurological component, they look closely at the labor history. Was there a prolonged pushing phase, or forceps, or a vacuum use? Those drastically increase the risk of nerve compression.
That makes sense.
They also utilize quantitative sensory testing to map exactly which tissues are numb and sometimes use diagnostic nerve blocks. If numbing the pudendal nerve temporarily makes the chaotic symptoms vanish, it confirms the nerve is the culprit.
Which forces us to look at the treatments. Because at the root cause is this complex overlap of muscle avulsions, stretched fascial ropes, and suffocated nerves, we have to move way beyond the standard Kegel advice.
Absolutely. The field of urogynecology has evolved tremendously to target these specific mechanisms. Starting with the mechanical side, the overstretched fascia, we see the rise of energy-based devices.
The journals specifically detail radiofrequency, or RF, and dynamic quadrupolar radiofrequency, DQRF.
Right.
And this isn't a surgical procedure. It's using wands to apply energy and heat to the vaginal tissue. I need a breakdown of how heating the tissue fixes structural laxity.
It relies on cellular biology and the body's natural healing cascade. When practitioners apply precise, controlled radiofrequency energy to the subepithelial layers.
Which is the tissue just beneath the surface lining?
Exactly. It creates a targeted thermal effect. This localized heat serves a very specific purpose. It reactivates fibroblasts.
Okay, fibroblasts. Are those like the scaffolding builders of the cells?
That is their exact role. Fibroblasts are the cells responsible for synthesizing the extracellular matrix, which includes collagen and elastin.
Oh, okay.
By heating the tissue to a specific temperature, the radiofrequency essentially tricks the body into thinking there is a mild injury. This triggers an inflammatory healing response, stimulating the fibroblasts to rush to the area and lay down entirely new networks of collagen and elastin fibers.
So it's forcing the body to rebuild and tighten those fascial ropes from the inside out.
Exactly. It restores tensile strength and elasticity to the connective tissue without requiring a single surgical incision. It directly addresses the mechanical laxity that muscle exercises just cannot reach.
Here's where it gets really interesting.
Okay.
That covers the structural side, but the sources also detail how to treat the neurological side. That stretched, misfiring pudendal nerve.
For the neuromodulation therapies.
Yes, neuromodulation. And the standout treatment here is TTNS, transcutaneous tibial nerve stimulation. The clinical trials show that TTNS not only improves pelvic floor muscle strength, but it significantly improves patient scores on the vaginal laxity questionnaire.
It's a great tool.
But to do this, they put an electrical stimulator patch on the patient's ankle. I read that 3 times. You treat vaginal looseness and pelvic nerve damage by putting an electrode on the ankle.
It sounds a bit like magic, doesn't it?
It feels like trying to reset a house's broken Wi-Fi router by pressing a button in the neighbor's garage. How are those two connected?
If we connect this to the bigger picture, to understand the mechanism behind the neighbor's garage, you have to trace the body's internal wiring diagram back to the spinal cord.
Okay.
The tibial nerve runs all the way down your leg and into your ankle, but if you follow that nerve pathway up the leg, it originates in the sacral plexus, specifically branching out from the nerve roots at the S2 and S3 levels of the lower spine.
Okay, the tibial nerve plugs into S2 and S3 in the spine.
Now, trace the pudendal nerve, the one deeply embedded in the pelvis, serving the vagina and pelvic floor. It originates from those exact same S2 and S3 sacral nerve roots.
Oh, they share the same switchboard.
They plug into the exact same outlet in the central nervous system. Because the pudendal nerve is located deep inside the pelvis, making it really difficult to reach and stimulate without invasive procedures, practitioners use the tibial nerve at the ankle as a neurological backdoor.
So by sending a mild electrical impulse into the ankle?
That impulse travels up the tibial nerve, hits the S2 and S3 switchboard in the spinal cord, and modulates the entire neural circuit. It calms down the erratic signals, helps reset the reflex pathways, and restores normal sensory processing to the pelvic floor. It reboots the pudendal nerve's reporting system without ever having to directly touch the damaged pelvic tissues.
That is an incredibly elegant workaround, using the body's own shared nerve roots to fix the problem remotely.
It really is.
And the studies show that as the nerve begins to process signals correctly again, the sensory feedback improves, and that neurological illusion of laxity starts to diminish.
Yeah, the brain gets the right data again.
But what happens if the nerve damage is beyond a simple reboot? The sources mention severe cases of pudendal neuralgia, where the pain, the numbness, or the golf ball sensation is just intractable.
When dealing with chronic nerve entrapment or intense neuropathic pain that doesn't respond to surface stimulation, the interventions have to scale up. One approach involves using botulinum toxin, commonly known as Botox, injected directly into the pelvic floor muscles.
Wait, using Botox for pelvic floor dysfunction?
Yeah. It utilizes the paralytic properties of the toxin. When the pudendal nerve is injured or irritated, the surrounding pelvic muscles often go into a state of chronic, painful spasm as a guarding mechanism.
Like they're trying to protect the area.
Exactly. But ironically, this tight spasm ends up compressing the nerve even further, creating a vicious cycle of pain and nerve starvation. Injecting Botox temporarily paralyzes those specific spastic muscles.
Oh, I see.
It forces the pelvic floor to drop and relax, breaking the pain cycle and giving the trapped pudendal nerve the physical room it needs to breathe and heal.
And for the patients where even releasing the muscles doesn't stop the chaotic nerve signals.
The next tier involves implanted sacral neuromodulation. This is essentially a pacemaker for the pelvic nerves, surgically implanted under the skin to continuously regulate those S2 and S3 nerve roots.
That's intense.
It is. In the most extreme cases of chronic pelvic pain, medicine even looks to deep brain stimulation, placing electrodes in the pain centers of the brain to block the faulty signals at the final destination. The treatments span an incredible spectrum, from resting a nerve via an ankle patch, all the way to rewiring how the brain perceives the pelvis.
It shows how far the medical understanding has progressed. We are miles away from simply telling women it's all in their heads, or that they aren't trying hard enough with their pelvic floor exercises.
Absolutely.
So what does this all mean for you listening? It means that postpartum bodily changes are a highly complex, multi-layered issue. If you are experiencing changes in sensation, a pervasive feeling of looseness, or confusing pelvic pain, your symptoms are real.
They are very real.
And they're measurable. Whether you're dealing with a mechanical breakdown of your fascial ropes, or a neurological misfiring where an exhausted pudendal nerve is projecting a sensory illusion of laxity, You are not broken beyond repair. Your body is simply requiring a more sophisticated diagnostic map to find the right modern intervention.
And if we connect this to the bigger picture, it leaves us with something quite profound to consider regarding how we experience our own physical reality.
How so?
Well, we rely entirely on our senses to tell us the truth about our bodies. But if our brain's perception of physical space, tightness, and structure inside ourselves is entirely at the mercy of microscopic electrical signals from a single delicate nerve,
Yeah.
how many other physical sensations that we accept as absolute undeniable reality are actually just cross neurological wires?